Good afternoon, everyone. My topic is about the evaluation of new preoperative interventions in order to enhance recovery after major abdominal surgery. My name is Sebestyén, and I'm a pediatrician at Heim Children's Hospital. My supervisors are Zsolt Molnár and Marcel Virág, and my SMSs are Clementina Ocska and Fanny Dembrovski. I believe that there are some old principles and paradigms in perioperative patient care that are kind of old school now. We need new approach, we need change. So my mission is to provide high quality of evidence to support this process. In the next couple of minutes, I would like to tell you about, my two ongoing projects. The first one is about the effects of preoperative carbohydrate loading on postoperative outcomes in patients undergoing elective major non-cardiac surgery. This is a systematic review and a meta-analysis. Traditionally, after midnight prior surgery, it is forbidden for patients to consume any kind of food or fluids. This is called preoperative fasting, which is technically a stress situation for the patient, and it can contribute to perioperative insulin resistance and hyperglycemia. And when this kind of stress due to hunger adds up with the surgical stress and the surgical trauma, these together can contribute to an increased risk of postoperative complications. Despite all these facts, preoperative fasting is still a worldwide routine. However, the most recent enhanced recovery after surgery guidelines strongly recommend the preoperative carbohydrate loading instead of fasting, but the quality of evidence is still low or moderate. So in our study, we would like to investigate the effects of preoperative carbohydrate loading, and we hope that with this study, we can increase the level of evidence. Our clinical question is the following. Does preoperative oral carbohydrate load decrease the rate of postoperative complications compared to preoperative fasting in elective major non-cardiac surgery? We would like to include adult patients undergoing major non-cardiac surgery under general anesthesia. The intervention group will receive the preoperative carbohydrate loading, and the control group will receive placebo or daily fast. Our primary outcome is the length of hospital stay, but we have some secondary outcomes as well, such as postoperative blood glucose levels, insulin levels, and inflammatory parameters, because we hypothesize that preoperative carbohydrate loading is superior to fasting. You can see our search key and the number of the results we found in each databases. And after the selection, we have 55 articles that were eligible for the data extraction. Here you can see the forest plot of the length of hospital stay. We compared the recorded hospital stays of the intervention group and the fasting group. As you can see, the length of hospital stay of those patients who fasted spent almost 2 days more in hospital than those patients who received preoperative carbohydrate loading. So this is a clinically and statistically significant result. However, the heterogeneity is very high, and this is caused by that these studies performed many different kinds of populations. These patients underwent, for example, thyroidectomies, colorectal surgeries, craniotomies, and so on. We didn't experience the same significance with the placebo group, and the heterogeneity is high as well. But there may be another reason for that, and it's that we're uncertain about the metabolic effects of the used placebos. We measured the glucose levels on postoperative day 1 and 2 in the preoperative carbohydrate group and the fasting group, and we did the same with the placebo group on postoperative day 1. As you can see, there's no statistically significant result here, and not clinically as well. The same is on the postoperative day 2. There's no statistically or clinically significant result with the placebo group, but I would like to highlight the first study, the Perone study, which clearly favors the carbohydrate loading over placebo. And the reason behind that this carbohydrate drink contained not just carbohydrates, but whey protein as well. So this can be a promising new direction. And so the heterogeneity of the patient population is a serious limiting factor, and the administration of the intervention differed in each study, but we have a big number of eligible randomized control trial, and there was no incidence of adverse events. So this means that preoperative carbohydrate loading is a safe intervention and may reduce the length of hospital stay, but we're uncertain about the effects of on the postoperative glucose levels, and we're uncertain the metabolic effects of the used placebos as well. So implication for practice is the reduced length of hospital stay, and implication for research that we would like to recommend the further studies to be performed with a more homogeneous population, and effects on the V protein have to be investigated as well. But the next project, it's about multimodal individualized goal-directed fluid therapy, MyGDFT, for short in patients undergoing pancreatic surgery. So hemodynamic management during major surgery is a must because the patients cannot control their own circulation due to sedation, and doing it adequately is a must because inadequate management can result in either tissue hyperperfusion or fluid overload, and both are associated with worse postoperative outcomes. And what we already know is that goal-directed fluid therapy, or GDFT, is a well-working strategy. So we think if we complement this strategy with a multimodal contextualized concept developed by our group, we can achieve further improvements in the outcomes. So this will be the first study that would compare MyGDFT with conventional fluid therapy. So our aim is to investigate the effect of this intervention. Here's our clinical question. Does MyGDFT reduce the postoperative complications compared to conventional fluid therapy in patients undergoing elective pancreatic surgery? So our patient population includes adult patients undergoing pancreatic surgery, or the intervention group will receive MyGDFT, the control group will receive conventional fluid therapy. About the outcomes, I would like to tell you a little more about 3 slides later. We hypothesized that MyGDFT is superior to conventional fluid therapy. And here's the implication. We believe it shortens the length of hospital stay and results lower overall complication rate. You can see the inclusion and the exclusion criteria. We would like to include adult patients undergoing pancreatic surgery, as I mentioned, and ASA 1, 2, and 3 patients only. We would like to exclude ASA 4 patients, pregnant or lactating women, and patients with inoperable pancreatic cancer. You can see that we compared the intervention group with the conventional group. Arm A will receive MyGDFT guided management, Arm B will receive conventional management, and the differences between the two management, I highlighted them with red. So here are the outcomes. We would like to use starts with the definition about the overall complication rate, which are infection, respiratory, cardiovascular, abdominal, renal, and other complications. We have some secondary outcomes, as I mentioned, such as length of hospital stay, intraoperative urinary output, and so on, as you can see. So here's a little overview about my 2 ongoing projects, and I would like to thank you for your kind attention. If you have any questions, please go on.
How you manage this preoperative carbohydrate loading? Is this a specific product or a sandwich? Just for joke.
No, these are drinks and that act like a morning meal, actually. There are some specific products, but in some RCTs we found that they just gave the patients water with sugar in it and some salt. So there are some opportunities.
Can we go to that slide on the placebo? Yes, this one.
Okay.
So there are multiple things. And one thing is that 2 studies stand out. I mean, it's very different than the others. The other thing is that, so what is placebo? You already mentioned that there might be certain things in the placebo. So is there any explanation for this? I mean, 2 studies is actually in favor and 4 studies are, or 5 is absolutely not.
Yes, so there are a lot of different types of placebos. In the first one you see, pure water was used as a placebo. Mm-hmm. There wasn't anything in it, it was just tap water, but in the other studies, the placebo contained artificial sweeteners. Some of them was orange juice based, and that's why I said that we are not sure about the metabolic effects of these placebos, because we're not sure what effect the orange juice based placebo has.
On the previous slide, you just said starving or something like that, fasting.
Yes, fasting, it is called fasting.
So does it also mean that they don't get fluid replacement, or do they get?
It is forbidden for them to consume fluids after midnight prior surgery.
You get the placebos. So
yes, these are double-blinded studies because the placebos were administered at the same time that the intervention was administered.
Yeah, so actually then in this way, if I'm right, then the very first study is very similar to the other one, when the placebo is only water.
Yes, because water does not contain any components that may have an effect of these outcomes.
Yeah, I mean, this is still, to be solved. Why actually 2? Because there might be some other things too. In 2 studies that you actually seem to have an effect, and in 5, absolutely nothing.
Sorry again, can you repeat that?
The first 2 is different from the next 5. So again, I'm asking that, do you have any clue that what would be the reason for this?
The only reason we found in these articles that the first 2 used pure water and as placebo administered at the same time as the carbohydrates. But the other RCTs you see on this plot used different placebos than water. They used mixtures of artificial sweeteners. And
I have seen in your research implication that you said that homogeneous population is needed. Do you have any suggestion how to reach this kind of homogeneous population in the further studies?
Yes, so a population are patients who are undergoing non-cardiac surgery. This is a wide term, because non-cardiac surgery means colorectal surgeries and thyroidectomies and total hyperarthroplasties. So these are very kind of different surgical procedures. And a recommendation is that to perform a meta-analysis on specific type of surgeries, for example, pancreatic surgery only, and so on.